In this unit, we are going to look at problems associated with the kidney. Altered renal function usually involves a certain degree of waste retention or water and electrolyte imbalances. This is often due to the loss of nephron function. This loss is usually reversible, but nephrons are permanently lost. They cannot regenerate. However, due to a large number of nephrons, there is a safety margin. The kidney is similar in this way to the liver because we only use roughly 10% of our nephrons on a daily basis. Also, the remaining nephrons can hypertrophy, increase in size. This won't compensate completely, but it can help. Lost nephrons eventually will be replaced with scar tissue. The first set of disorders involve the glomerulus. The glomerulus is the first portion of the nephron where filtration of the blood occurs. These disorders involve any change in the glomerular components that will make up the filtration membrane. Anything that changes these will affect the filtration process. In normal filtration, fluid passes through the glomerular capillaries into the Bowman space. First, this fluid passes through fenestrated capillaries, the glomerular capillaries, and then slits formed by pedicels. These are off the podocytes. These are special cells that surround the glomerulus. Anything that alters one of these two components will alter the filtration process. Next are some basic terminology associated with glomerular disorders. The first is glomerular nephritis. This is a very general term used to describe a group of glomerular disorders. Then we can become more specific. Acute glomerular nephritis is a benign disorder and tends to resolve itself quickly. Rapidly progressive glomerular nephritis advances quickly and can lead to death in a matter of a few months. Chronic glomerular nephritis is more long-term, and this can take years to ultimately run its course. These terms are used by clinicians to describe the disease. Diffuse glomerular nephritis means that most or all of the glomeruli are involved. Focal glomerular nephritis means only some are abnormal. And then segmental glomerular nephritis means some capillaries in a given glomerulus are involved while others are not. These terms are used by pathologists to describe the lesions. Minimal change disease means that there is little histological alteration. You will see changes primarily in the processes of the podocytes. Proliferative means there is an increase in some cellular components of the glomerulus or tissues associated with it. All around the glomerulus are cells that act like packing material or supporting material. These are known as the mesangium. And in this condition, it's these cells that are proliferating, and then they interfere with the filtration process. Membranous glomerular nephritis means antibodies bind to antigens of the basement membrane of the glomerular capillaries, and this interferes with filtration. These terms are for histological description. The last two terms represent combined conditions. These include membranoproliferative glomerular nephritis, where you see cellular proliferation as well as basement membrane thickening in the glomerulus, or diffuse proliferative. This describes the distribution of the various lesions. The dominant factor that results in the destruction of the glomerulus is actually the immune system. This process is initiated by the presence of immune complexes in the glomerulus. These immune complexes can form via two possible ways. One is antibodies are made to the glomerular basement membrane. They reach the glomerulus and bind to the capillary basement membrane. The other way are via antibodies against a circulating antigen. They combine in the plasma and form a complex. The role of the kidney is to filter the blood. When these complexes make it to the kidney, they become trapped in the filtration membrane. These complexes, once formed or trapped, will then activate the complement cascade. This results in inflammatory changes that cause cell damage, scarring, and ultimately glomerular loss. These immune complexes can result in many forms of acute glomerular nephritis. What is the result of activating complement? You will see the production of chemotactic proteins. These proteins promote the filtration of macrophages and neutrophils. Normally, they do not filter out and will stay in the blood. These macrophages and neutrophils begin to engulf the complexes and, in the process, release enzymes and toxins that damage the capillary wall. This damage then exposes the basement membrane and promotes the process of platelet aggregation. This is then followed by fibrin formation and deposition in the glomerulus. Over time, the fibrin will be replaced by scar tissue, which ultimately results in permanent loss of the glomerulus. Chronic disease is due to the large reserve capacity of the kidney. Chronic disease can go unnoticed for a long period of time. Once signs and symptoms appear, this indicates that the reserves have been destroyed with no possibility of regeneration. We're unsure of what actually causes the increased proliferation of the various components in proliferative glomerular nephritis. It is felt that it may be a response to the damage or due to inflammatory changes in the glomerulus. What are the sources of these antibodies or immune complexes? One source is autoimmunity, where the person makes antibodies to their own self-antigens. However, with glomerular nephritis, there is a strong link to both hepatitis B and streptococcal infections. We make antibodies to these two organisms, and they form complexes in the plasma. These complexes then become trapped when the blood carries them to the glomerulus. Also, many diseases produce a secondary glomerular disorder. Diabetes mellitus, lupus, Goodpasture syndrome, and bacterial endocarditis can also result in glomerular nephritis. This is a flow chart showing how once immune complexes are deposited in the glomerulus, how they can result in damage. This picture indicates what is happening in the glomerular capillary. The darker brown represents the capillary itself. These cells around the outside, these are the mesangial cells or the packing cells. The cells right along the outside of the capillary, those are the podocytes. The black represents the immune complexes that have become stuck as they were being filtered through this membrane. These larger cells here represent the neutrophils and the macrophages. Notice how they are engulfing the complexes and as a result causing damage. This can result in activating or stimulating platelet aggregation. What are the consequences of this glomerular damage? What can happen as a result? One condition is nephrotic syndrome. With nephrotic syndrome, you will see pronounced proteinuria because the glomeruli can no longer retain proteins. Albumin is the smallest protein in the plasma and usually the first to be able to pass. However, if you were to look at albumin, the size of albumin and the size of the filtration membrane, albumin should be able to be filtered. However, due to charges, it cannot be filtered out of the blood. The lining of the glomerular capillary maintains a negative charge under normal conditions. Albumin also has a negative charge. These two like charges repel each other, and this is what normally keeps albumin in the plasma and does not allow it to be filtered out. Remember, too, that albumin plays a major role in regulating blood osmotic pressure. So if albumin ends up being lost in the urine, this will decrease blood osmotic pressure. This results in less fluid re-entering the blood, and this can result in edema. Eventually, the glomerular damage reduces the glomerular filtration rate enough to activate various reflexes that will retain sodium and water. This is done through the renin-angiotensin system, which ultimately leads to an increase in aldosterone secretion. This will just complicate the edema issue. Now, why do the proteins leave? As I said before, normally the basement membrane carries a negative charge that repels the negatively charged proteins. In nephrotic syndrome, the damage disrupts these charges, and this is what allows the proteins to escape. This is just a flow chart showing what happens, the glomerular damage in nephrotic syndrome, and how it results in protein loss. The other consequence is nephritic syndrome. Here you see pronounced hematuria. The damage to the glomeruli allow red blood cells to escape. The reduced glomerular filtration rate causes a decrease in urine output, oliguria, water retention, and the accumulation of nitrogenous waste in the blood, azotemia. Less protein loss is seen compared to nephrotic syndrome. This usually is the result of proliferative changes in the glomerulus. So the damage here is due to cell proliferation, and this creates pressures that result in the red blood cells being released. The basement membrane and its negative charges are okay. As a result, proteins do not tend to leave in great amounts. Once again, this is the flow chart showing how the glomerular damage leads to red blood cell loss. We are now going to move on to the next portion of the nephron, which is the tubular portion. This is where the processing of the final urine product occurs. These disorders also involve the renal interstitium. The renal interstitium includes the intercellular matrix that surrounds the tubular portion of the nephron, plus the peritubular capillary network. These capillaries also surround the tubular portion, and this is where supplies the capillaries for reabsorption, when materials are taken out of the urine and put back into the blood. This group of diseases are based on altered tubular processing. The general result of these disorders are usually water and sodium loss, as well as the retention of acids. There are two forms, pyelonephritis and interstitial nephritis. Starting with pyelonephritis, this is an inflammatory condition of the renal interstitium. It can also affect the calyces and the pelvis of the collecting system. The glomeruli are not affected unless the condition is prolonged. Pyelonephritis is the second most common cause of renal failure, right behind chronic glomerular nephritis. The cause of pyelonephritis is usually bacterial in origin, but it could be due to viruses or other agents may be responsible for the inflammation. These organisms can come from several possible sources. One source is hematogenesis, or bloodborne. These bacteria are coming from another infected site someplace in the body and are carried to the kidney via the systemic arteries. This is also sometimes referred to as descending pyelonephritis because the organisms descend onto the kidney. This can result in abscess formation and necrosis in the renal cortex. Other sources of organisms, they could be intestinal microorganisms of fecal origin, especially E. coli, Proteus, and Enterococcus. They could be vaginal microorganisms, or they could be other exogenous microorganisms. Together, this group is referred to as ascending pyelonephritis. The bacteria get into the urethra and gain access to the kidney this way. This source of organisms is more common in females due primarily to the shorter length of the urethra. In males, the urethra is significantly longer, plus males also have secretions from the prostate gland that have some antibacterial action. And this is just showing the difference between descending and ascending pyelonephritis. Now, how does this develop? Main cause is incomplete bladder emptying. This could be due to bladder abnormalities that involve inadequate urine expulsion pressure or a blockage of urine overflow. Normally, urine and the urinary tract are sterile, except in the distal portions of the urethra. Also, the normal flow of urine does not allow bacteria to grow. However, if emptying is incomplete, this provides a medium for bacteria in the urethra to begin to grow. Sources of blockage may be due to kidney stones, prostatic hypertrophy, pregnancy, pelvic inflammation, or possibly tumors. Once bacterial growth is established, these organisms can ascend up the ureters, into the collecting system, and ultimately into the kidney. How easy it is for them to ascend may also depend on a structural defect in the joining of the ureter to the bladder. There is a small flap of tissue that covers the junction between these two structures. Normally, this flap closes over the opening during bladder emptying so that the urine cannot backflow. If this junction is defective, now urine can back up and eventually get into the kidney. What are the types of pyelonephritis? The types are based on the duration as well as their severity. One form is acute pyelonephritis. This is a very common form and a relatively mild condition, usually bacterial in origin. This is the second most common infectious disease after those in the respiratory tract. Here you will see inflammation of the renal tissue that could lead to necrosis and bleeding in the mucous membranes of the adjacent collecting system. It may involve one or both kidneys. You often see the sudden onset of pain, chills and fever, pyuria, and bacteriuria. If it's severe, it can lead to necrosis of the renal medulla, ultimately resulting in renal failure. Treatment is often antibiotics. Chronic pyelonephritis is a slow, long-term deterioration of renal function. This tends to be asymptomatic until substantial damage has occurred. This can then lead to loss of the functional parenchyma. It will be replaced with scar tissue. Due to the lack of symptoms, patients don't tend to seek help until end-stage renal failure hits. At this point, they can no longer prevent water loss, regulate pH, or retain sodium. If obstruction is involved, this long-term back pressure will dilate the collecting system as well as the proximal ureter. This can result in renal failure, which will then require either dialysis or kidney transplant. Another disorder is interstitial nephritis. Here, there is an etiology other than infection. Here, the nephritis may be due to therapeutic drugs, exogenous toxins, or other toxic endogenous agents. Remember, the entire plasma volume circulates through the kidneys 60 times a day. Any substance in the plasma that is toxic has plenty of time and chances to do damage. Some common agents responsible for this disorder: metals such as copper, uranium, and mercury; organic solvents such as methanol, carbon tetrachloride, ethylene glycol, which is antifreeze; certain antibiotics, ampicillin, penicillin, sulfonamides, and tetracycline; aspirin and acetaminophen; insecticides; and also gout due to the higher levels of both calcium or uric acid. Next, we will look at kidney stones, known as urinary calculi, nephrolithiasis, or urolithiasis. Stones typically form in a single kidney. They may stay in the kidney, the collecting system, or they may pass through the ureter to the bladder. However, they usually end up becoming lodged somewhere, causing obstruction to urine flow. The actual incidence of stones is high, but many present no symptoms, so you are unaware that you actually have them. The incidence of stones tends to peak in males between the ages of 30 and 50. Stones can vary in size as well as number. They can also vary in shape. Some are nice and smooth and round. Others are polygonal. Some can be jagged and rough. And some, as this bottom picture here, resemble deer antlers. These are called staghorn calculi. This one here is filling. The stone is so large that it fills the entire collecting system. The composition of stones are typically crystals of inorganic ions embedded in proteins. These ions include calcium, oxalate, phosphate, and urate. These stones form due to an increased concentration of these ions in the urine. This will lead to them precipitating out as a stone. This increased concentration may be due either to an increased secretion of the ion into the urine itself, or due to a decrease in urine volume that makes it appear that the ion is more concentrated. They can also form due to changes in the acidity of the urine. Here, the volume of urine would be normal, but if the pH decreases, i.e. becomes more acidic, this will favor the precipitation of uric acid. If the pH increases, this will favor the precipitation of phosphates. Usually stones form due to some problem in metabolism. For example, hypercalciuria. This is high levels of calcium in the urine, which is the most common cause of kidney stones. This usually results from an increase in intestinal absorption. If you absorb more from your diet, this is going to require an increased need to excrete more calcium through the urine to maintain homeostasis. It could also be due to an increased secretion of parathyroid hormone. This too will cause plasma levels of calcium to increase, resulting in more calcium that will need to be excreted. Other causes would be urinary tract infections and chronic pyelonephritis. Complication of the stones occur when they become obstructed. This can result in urinary stasis and an increased back pressure, resulting in destruction of the renal parenchyma, possible secondary infections, and further renal damage. The symptoms of kidney stones, if and when they do occur, include renal colic, which is very severe pain. This typically originates in the ureter and radiates to the upper leg. This is due to the peristalsis that is occurring in the ureters that end up pressing on the stone. You will see chills and fever. This is often seen with passage of the stones, and hematuria due to abrasion of the mucosa as the stones are passed. Treatment. One option is surgery. This would be done in cases of severe pain, infection, bleeding, or if the stones can't be passed on their own. You can try to break up the stones so they can be passed naturally by using either a cystoscope or ultrasound. Drugs can also be used to attempt to dissolve the stones or prevent them from getting any larger. What the drugs do is they act by decreasing excessive excretion of the material that is responsible for the formation of stones, or by changing the pH so the stones will dissolve. General overview of the etiology of renal dysfunction as we have looked at it so far. Two basic pathways. One is that microorganisms get into the urinary tract to the kidney, resulting in renal dysfunction. Remember, this is the ascending. Or microorganisms, antigen-antibody complexes, or toxins get into the bloodstream to the kidney and cause dysfunction. This would be the descending way to look at dysfunction. A better way to look at kidney disease is, where is the actual problem? Is it pre-renal, referring to the blood supply to the kidney? Is it renal, which represents the kidney itself? Or is it post-renal, involving the urinary tract? So this is the flow chart. Is it pre-renal, something to do with the blood supply? Is it the kidney itself? Or is it post-renal, involving the urinary tract? Pre-renal disease means the root of the problem lies in the renal blood supply. The main problem is usually ischemia. A decrease in renal blood flow will result in inadequate glomerular filtration and a decrease in the kidney's ability to meet homeostatic regulation as well as excretion requirements. This will present itself as oliguria and a loss of excretory function. Now, how can this ischemia develop? One way could be through renal artery stenosis. This is often the result of atherosclerosis within the renal artery, with possible thrombosis on top of it. Another cause would be low systemic blood pressure, i.e. hypotension. In normal conditions, normal fluctuations of blood pressure, the kidney arterioles respond to this to provide constant glomerular filtration pressure. This is known as autoregulation. They can deal with minor changes up and down, but not drastic changes. In circulatory shock, in this case, the blood pressure drops below what the kidneys can autocompensate for. Another condition, nephrosclerosis, this is actually associated with hypertension. This represents a thickening of the kidney arterioles, which will also result in less blood delivery to the kidneys. This is the flow chart showing the various causes of renal ischemia. It could be hypotension, it could be atherosclerosis resulting in stenosis, or nephrosclerosis, which is high blood pressure. In post-renal disease, the main problem is urinary obstruction. This problem may be exaggerated by the faulty joining of the ureter and the bladder. The results of this backflow will be a compromised excretory function, as well as direct damage to the renal tissue. Sources of this obstruction include kidney stones in the ureter or the renal pelvis, and also compression due to a swollen or neoplastic tissue. This is very common in males with a swollen prostate. Now, so far in both the pre- and post-renal conditions, the kidney was able to function normally initially, but then suffered dysfunction due to some other condition. Renal disease, or intrarenal, this is where the kidney itself is at fault. This would be where glomerular nephritis fits in, where you see changes in the glomerulus that lead to nephritic and nephrotic syndrome, or damage to the renal interstitium due to bacterial infections, drugs, and toxins. All of this ultimately leads to renal failure. Uremia is a part of both acute and chronic renal failure. Uremia refers to the presence of protein metabolites in the blood due to progressive loss of renal function. These protein metabolites are very difficult to excrete. They include things such as urea, creatine, creatinine, guanidine, and uric acid. These are all classified as toxins. Once uremia develops, the underlying renal disease has progressed too far to be responsive to any treatment. What are the effects of these toxic materials building up in the blood? One, you will see an inhibition of membrane ion transport mechanisms in other cells in the body. This is responsible for many of the systemic problems associated with this condition. You will see fluid and electrolyte imbalances. You will see water retention and acid-base disturbances. You will see an increase in potassium retention. This will cause cardiac arrhythmias, as well as cardiac and skeletal muscle weakness. You will see loss of weight due to the anorexia, vomiting, and diarrhea. Uremic encephalopathy. These are nervous system effects. You can see confusion, apathy, convulsions, and coma. And lastly, you will see an inhibition of platelet factor 3. This will result in blood coagulation problems. Now, the two forms of failure are acute and chronic. Acute renal failure is rapid and usually a reversible decline of renal function. There are three main categories that can cause the oliguria: acute pyelonephritis, toxic nephropathy, or renal ischemia. Renal ischemia develops when there is a decrease in systemic blood pressure. Remember, for example, cardiovascular shock. This could be due to trauma, surgery, hemorrhaging, burns, infection, or cardiac damage. Acute tubular necrosis represents damage to the nephron tubules as a result of these nephrotoxins that were mentioned earlier. This usually results in less damage than the ischemia, therefore the prognosis is usually better. Acute pyelonephritis in severe cases can lead to necrosis of renal tissue. Recovery. How long the oliguria continues depends on the severity of the damage as well as on the tubular regenerative capacity. Remember, you cannot remake a new tubule, but they can recover if the damage is not severe. You will see a period of diuresis as the restoration of function continues. This represents an attempt to rid the body of the excess fluid that was retained. Regeneration and restoration of function can take several weeks. It is a very gradual process. Acute renal failure can be fatal if the damage ends up being severe. In chronic renal failure, the effects are irreversible. This typically follows chronic glomerular nephritis or severe pyelonephritis. You will only see the abnormal effects on homeostatic regulation and excretion after somewhere between 50 and 70% of the total nephrons are lost. At this point, the consequences of renal insufficiency emerge and chronic renal failure develops. What are the causes of chronic renal failure? Basically, all of the problems associated with uremia. These ultimately progress to what is known as end-stage kidney. Another cause is polycystic kidney disease. This is a genetic disorder where the kidneys are filled with multiple fluid-filled cysts. These will cause the kidney to end up being distended. The effects and symptoms: 1 is excessive water loss. This is seen during early end-stage disease. This is the result of the loss of the resorptive capacity of the tubules is greater than the reduction in filtration at the glomeruli. Let's review. In a normal functioning kidney, the glomeruli filter approximately 180 liters of fluid a day, and then the tubular portion is able to reabsorb 99% of that, so that the net output is roughly 1.8 liters. Now here in chronic renal failure, the glomerular filtration rate has fallen to 90%. So instead of filtering 180 liters, we are only filtering 18 liters a day. But the tubules can only reabsorb 50% of that instead of the usual 99%. This results in a daily loss of 9 liters. This is the source of the excessive water loss. Later on, as the glomerular function is further reduced, you will see oliguria or anuria. Usually these people can only survive with aggressive therapeutic intervention, such as transplant or dialysis. And this leads us into renal dialysis. This is the process whereby waste and uremia toxins are cleared from the blood and electrolyte balances are restored. The term dialysis refers to the dialysis fluid that is used to help establish a favorable concentration in the patient's blood. There are 2 methods that can be used. Hemodialysis, also known as extracorporeal dialysis because it is done outside of the body, and peritoneal dialysis that uses the peritoneal cavity of the patient. In hemodialysis, the patient's blood is passed through a hemodialyzer outside of the body. Blood flows through a series of chambers bounded by a semi-permeable membrane. Around these chambers, you will find the dialysate. The composition of the dialysate favors the movement of waste, toxins, and unwanted electrolytes out of the blood, and any needed substances into the blood via diffusion. The pores of the membrane are large enough to allow water, electrolytes, and toxins to pass, but small enough so that the formed elements stay in the blood. The composition of the dialysate can vary depending on what needs to be removed from the patient's blood, but the basic composition of electrolytes usually remains the same as normal plasma. One can also compensate for the kidney's inability to regulate water. For example, if the kidneys cannot excrete enough water, all one needs to do is raise the pressure at which blood is forced through the chamber, and this will force water out of the blood. The other type of dialysis is peritoneal. This uses the peritoneal cavity as a dialysis chamber and the peritoneal membranes as the dialysis membranes. These membranes provide over 2 square meters of surface area for diffusion. The dialysate will be passed into the peritoneal cavity and allowed to remain for a period of time. This will allow for diffusion and osmosis to occur between the blood and the dialysate. The cavity is cleared and the process will be continued until the desired blood chemistry is achieved. People often receive dialysis while they are awaiting kidney transplant. Kidney transplantation is replacing a diseased kidney with a normally functioning one. There are 2 main obstacles, though, to transplantation. One is obtaining a kidney, and second is the fact that you must work fast to avoid ischemic damage to the organ. 2 common sources of kidney. One is a living donor, usually closely related to the recipient, and the second would be an unrelated donor or a cadaver. The anoxia tolerance, or how long the kidney can tolerate the lack of oxygen. Warm ischemic time is only 1 hour if the kidney remains at body temperature. Cold ischemic time is up to 10 hours if the kidney is kept at 4 degrees centigrade. When the kidney is replaced, it is not placed in the same spot as the old one. Instead, it is placed slightly lower in the right iliac fossa. This site is closer to the urinary bladder. The reason is because it is often hard to retain branches of the renal artery to supply the distal portions of the ureter when the kidney is removed from the donor. This site of implantation allows for shorter proximal ureter and its blood supply and to be able to reach the urinary bladder. Also, the recipient's diseased kidney is usually not removed. And these pictures show the typical placement of a new kidney. One of the big problems with transplantation is the risk of rejection. Kidneys can be rejected in 3 different forms. One is hyperacute rejection. Here, urinary output declines by 90% within minutes to hours after implantation. After several weeks, the kidney is lost due to necrosis. This is often the result of anti-kidney antibodies that were present in the recipient's blood at the time of transplant. These are coming from previous exposure to the antigens, either through a previous blood transfusion, a previous transplant, pregnancy where fetal antigens have gotten into the maternal circulation, or exposure to bacterial antigens that cross-react with the kidney. Acute rejection occurs anywhere between the 1st and the 16th week post-op with a living kidney donor, or the risk is up to 2 years with an unrelated or a cadaver donor. Chronic rejection may take 2 years to develop. Here you develop antibodies to the vascular endothelium. The endothelium responds by proliferating and causing stenosis. You can also get antibodies to the basement membrane in the glomeruli. This will then result in protein loss, which is nephrotic syndrome. One way to try and prevent the rejection problem is through immune suppression, using a combination of various drugs. 3 common drugs that are used are cyclosporin, prednisone, and azathioprine. Cyclosporin and prednisone are both immunosuppressive. Prednisone is also anti-inflammatory, and azathioprine is anti-inflammatory as well. What these drugs do is to work to inactivate a portion of the immune system so that the patient cannot mount an attack. However, they do not come without risks of their own. The major problem with immune suppression is the risk of secondary infection because a portion of the immune system is being blocked, as well as tumor growth years down the road. The common cause of death in kidney transplant is not rejection, but rather this risk of secondary infection. Finally, we will look at ways to assess renal function. One way is through various blood tests. These look for the presence of toxic substances in the blood. Usually, these materials are nitrogen-containing byproducts of protein metabolism. One of these materials is creatinine. Creatinine is derived from creatine in muscle tissue. Normal values should be between 0.7 and 1.5 milligrams per liter. Another material is blood urea nitrogen. Urea is made in the liver from the nitrogen derived from the metabolism of amino acids, and then this urea will be excreted by the kidneys. Values for urea can change depending on dietary protein intake as well as protein metabolism. Blood urea nitrogen is used to screen for renal malfunction. If it is increased, the levels are increased above normal, this is a non-specific indication of impaired renal function. Normal values should be between 10 and 20 milligrams per liter. Both blood urea nitrogen and creatinine don't tend to become elevated until kidney damage is severe enough to reduce the kidney's reserve capacity. Another way to assess renal function is through a urinalysis. One thing you can do with the urine sample is a physical examination, looking at both volume and specific gravity. Altered urine volume, assuming normal fluid intake, can reflect altered renal function. Urine volume needs to be monitored over a 24-hour period. The term polyuria refers to an increase in output. This usually indicates that the tubules are unable to reabsorb water. Oliguria is a decrease in output. This is often associated with nephron damage and is seen with glomerular nephritis and pyelonephritis. Anuria means no output. This indicates a decrease in renal blood flow or obstruction or renal damage. Specific gravity is the weight of urine compared to the weight of pure water. Pure water has a weight of 1.000. The cause of the difference from water is the weight of solutes that are suspended in the urine. Specific gravity is an indication of the kidney's ability to concentrate urine. Loss of the tubule's ability to concentrate the urine will produce a specific gravity of about 1.001, which is very close to water. You can also do a chemical examination of the urine. One is to look at protein levels. Most protein is reabsorbed, so normal levels should be very low, less than 150 milligrams per day. Albuminuria is when you see increased levels of albumin in the urine. This is also known as proteinuria. Typically indicates damage to the filtration membrane that is associated with glomerular nephritis and some forms of pyelonephritis. You can also do a microscopic examination of the urine. One thing to look for is blood, both red blood cells and white blood cells. When you see red blood cells in the urine, this is associated with glomerular damage or disruption of the nephron vasculature or possible damage to the urinary tract. Elevated white blood cells indicate inflammation of the kidney or the urinary tract. You can also look for casts, which are particles in the urine that originate when tubular material first gels and then dislodges to pass in the urine. Casts typically form when the tubule secretes protein into its lumen. What you want to do is analyze the cast for its components. For example, is the cast just protein, or are there red blood cells or white blood cells associated with it? If you see red blood cells in the cast, this is a sign of glomerular damage. White blood cells in the cast are often seen with pyelonephritis and some glomerular nephritis. Tubular cells in the cast indicate pyelonephritis, advanced glomerular nephritis, or toxic damage to the tubules. And then lastly, you can do a biological examination where you are testing for bacteria. Bacteria may be a part or represent inflammation. Remember, urine is normally sterile at the kidney until it reaches the distal portion of the urethra. Elevated levels of bacteria indicate an infection. One last assessment would be to perform clearance tests. These attempt to assess how the nephron processes the blood that is delivered to it. These will compare the amount of the material in the urine with that which is present in the blood. These materials may be a normal part of the blood, or they may be something that is injected into it, and then look at how well it's cleared. Clearance tests measure the kidney's ability to clear this substance from the blood. One clearance test is to look at creatinine. The amount of creatinine in urine reflects the glomerular filtration rate. Creatinine is freely filtered at the glomerulus, and none will be reabsorbed. However, some small amounts may be actively secreted, so this may make the levels appear to be slightly elevated. Normal levels of creatinine should be between 91 and 130 mils per minute. Urea clearance also indicates glomerular filtration rate. However, some urea will be reabsorbed, so its clearance is only about 60% of the actual filtration rate. Normal clearance should be between 60 and 100 mils per minute. The final clearance test is inulin. Inulin is a carbohydrate that is not usually present in the blood. This material will be injected in the blood and should be freely filtered at the glomerulus. None will be reabsorbed, and none should be actively secreted, so this should be the most accurate reflection of the glomerular filtration rate. Normal value should be between 105 and 150 mils per minute.